Good morning, students. Today we are going to discuss about one of the topic in obstetrical in gynecological nursing, that is thyrotoxicosis in pregnancy. Thyrotoxicosis, it is a clinical condition which is caused by the excessive thyroid hormones, that is T3 and T4 in the blood. During the pregnancy time, the thyroid dysfunction is commonly it will be present for the both mother and fetus, and we have to find out in a yearly diagnosis. And if you are giving a proper management is very essential if the mother have thyrotoxicosis. Thyrotoxicosis, it is a in pregnancy means an overactive thyroid. It is most commonly from Graves' disease or temporary gestational hypothyroidism. So due to this specific hormone, it increase the thyroid hormones in the pregnant time, and it requires careful management, and we have to prevent some serious risk or complication like miscarriage, preeclampsia, and preterm birth, and also fetal issues. So what is the incident about here? The thyrotoxicosis most commonly 0.1 to 0.4 percentage in all pregnancies, and 85 to 90 percentage of the cases nearly accountable of Graves' disease. And gestational transition thyrotoxicosis is seen in about 1 to 3 percentage of the pregnancy. It is very mild and self-limiting, and more common in the woman with previous any history of thyroid disease. So what is the causes of thyrotoxicosis? Most common cause it is Graves' disease and gestational transit thyrotoxicosis, toxic multinodal goiter, and thyroiditis, and excess intake of thyroid hormones. What are the physical changes happen because of the thyroid? It increase the thyroid binding globulin, and it increase the demand for thyroid hormones, and HCG stimulate the thyroid hormone production, and it increase the mild T3 and T4 level in the blood. What are the clinical manifestation for the mother? Weight loss or poor weight gain present, a heat intolerance, palpitation, tachycardia and tremors, excessive sweating, anxiety and irritability, goiter and exophthalmos. For the Graves' disease. And fetal effects, intrauterine growth restriction and prematurity, low birth weight, fetal or neonatal thyrotoxicosis, and fetal tachycardia. How we can diagnose to find out thyrotoxicosis? So if you are checking in the serum TSH, it decreased, and elevated free T3 and T4, and thyroid receptor antibodies present, and if needed we can go with the ultrasound of thyroid. So radioactive iodine test is a contraindicated in pregnancy, so we should not do this radioactive iodine test. Next complication, maternal complication, it is pregnancy-induced hypertension and preeclampsia, heart failure, and thyroid storm, miscarriage, it will be happen. For fetal complication, stillbirth, congenital malformation, neonatal hyperthyroidism, and fetal distress. What is the medical management in the first trimester? We have to give a propylthiouracil 100 to 150 mg orally, and second and third trimester we have to give methimazole 5 to 15 mg oral, and beta blockers we have to administer, that is propranolol we are advised for the pregnant woman. Surgical management, surgery is considered only when medical therapy falls or fail is contraindicated. The types of surgery, it is subtotal thyroidectomy or near total thyroidectomy we have to do for the pregnant woman. If it is very needed only, we can do for the mother. Nursing management, we have to monitor the vital signs to the mother and check the any thyroid storm signs it will be present, and monitor the fetal heart rate above 120 to 160 is present or not. Ensure the medication compliance, provide the emotional support to the mother, and we have to check and also educate about the warning signs of palpitation, fever, and restlessness. In conclusion, thyrotoxicosis in a pregnancy is a high-risk condition requiring multidisciplinary care, proper medical treatment, and nursing management. It's play a vital role in ensuring the maternal and fetal well-being. I hope everyone understand about this topic. Thank you.